certainly have. We're very ancient. We go back a long way. We started looking at spiritual care and religion probably in the 1980s, long before it was fashionable or even wanted, actually. But particularly across all fields of medicine and more latterly in palliative care. Now, I've got 15 minutes to talk about the effectiveness, and I'm very interested in this as a trialist. I run a trials unit, so I'm very interested in is care effective, let alone spiritual care. And Harold Koenig and I are running a trial of spiritually based CBT in the States at the moment. So these areas are very close to my spiritual heart. But I'm going to have a spiritual health warning over what I'm about to present, because we've recently conducted a Cochrane review of does spiritual care work. But I'm on the hard line, the harder line. I'm worried by the 𝐒𝐓𝐷𝐶 definition. I may be the only one in the room who is. But I'm on the harder line of trying to define what this is, because I think when we get into things like a search for meaning, it can mean almost anything, is my worry. So the Cochrane review we've done is also rather narrow, and so that's therefore, that comes with that warning. So very quickly, because I'll run out of time. So, well, I won't rehearse this. In all illness, actually, we face a why and what's happening to me, but in terminal illness more than ever. And these, when spiritual and particularly religious, I think, issues are rekindled. Maybe, good. So, there's a lot of evidence out there, most of it very poor and very mixed, about the relationship between spirituality and well-being. And we've conducted a lot of longitudinal studies looking at ordinary people and their well-being and spirituality, not just people who are ill or facing illness. And it's very difficult to tease out what are the effects of belief or spirituality. I hate that word, but we can't think of any other better one, unfortunately. And then what are the impacts of treatments? So now, in this country, there's a lot of growing emphasis on spiritual care, and we see it in the NICE guidance. That's the sort of national guidance for treatments in this country. But it's very unclear what should be offered by whom and how do we measure effectiveness. And there's a potential for conflict with professionals' own beliefs here. So our aim was to try, and I'll emphasize the word try, classify and describe the sorts of spiritual care out there and try and crystallize it down to ones that we thought were reasonable studies and reasonably defined. And we were prepared to look at randomized trials, before and after, quasi-experimental studies, pretty much anything. I was rather nervous about this, but things that would look reasonably robust. And we looked at people who were adults, and we looked at this. Now, this is really to emphasize, and of course it's obvious here, we looked at this in life-threatening disease or terminal illness, not all illness. And participants could have any belief, but we wanted people in studies who were close to death. And this is a bit I was referring to earlier. We needed to have an explicit spiritual component in the intervention. So it could be things like prayer, but prayer with the person. As I'll come to in a minute, we did not look at issues like distant intercessory prayer, that sort of thing, and I'll explain why. Pastoral care from a religious leader. Meditation came into this, although once again you can argue about whether meditation should be in it. And the comparison groups we left pretty open. If these were experimental studies, we wanted to see what people came up with in terms of what they would compare it with. We didn't include things like mind-altering drugs. You could argue that these are an element of spirituality for some people. As I said, we didn't look at intercessory prayer. Most of the studies, I have to say, on intercessory prayer, in any case, are not in palliative care. And we didn't look at interventions that merely measured spiritual outcomes, because it's increasingly fashionable to bring in a spiritual outcome in any intervention, be it of any secular nature, and we didn't look at those. We wanted the effectiveness of a spiritual intervention to be the key here. Well-beings could be of any kind, of this broader kind. that you would say are more in the psychological domain and quality of life, but we also wanted to look at physical health outcomes, and mostly these are secondary outcomes in these studies, and even outcomes that we could in the informal carers. Well, we did the usual arduous work, looking at the databases, trying to screen out studies. We had 2 reviewers who were independently looking at these, and where we had disputes or arguments over the definition or inclusion, we did this by consensus. And we found 13 studies. This is what you often find, as you all know, in a systematic review. There's a lot of garbage out there, and slowly you get down to what you think might be valuable. But only 5, and they were all randomized trials, came into this. The other ones that were excluded, they were excluded for all sorts of reasons. It turned out it wasn't palliative care that they were involved with, and so forth. Potentially interesting studies, the other 8, but not in the actual field. And they were quite big, some of them. They weren't all small, and there was about 1,100 patients. They were all North American, which is not surprising. But what was very surprising was that none described the religious or spiritual characteristics of the patients. Now, this to me seemed absolutely strange, that if you're doing a study like this, you might want to describe at baseline the sort of patients you had. Now, there were 4 trials that included cancer and other terminal illnesses, and 1 late-stage AIDS. Now, 2 of them were meditation that explicitly had a spiritual basis to it, and 3 were more really about what you've been talking about today, kind of multidisciplinary team with a strong spiritual component, a professional in there giving spiritual care as part of a package. What worries me in these sort of comparisons, however, compared to, say, the meditation one, is that it's very dilute. You can't really, it's very hard to tease out what would be the spiritual nature, and none of the trials actually said how much contact that spiritual person or spiritual professional had with the patients. So this heterogeneity, as we call it, this kind of difference between the trials meant that we couldn't combine them. I won't go into that. That's just showing that not all the studies were robust, but they weren't that bad. And I've already said that. Basically, we found no significant benefit. So, not surprisingly, I think, but disappointingly, there was no clear advantage for spiritual interventions of this type. Just very quickly, what are the challenges to this? Because I think, I would not defend this systematic review with any great energy, because it's very hard to do. One, I and Peter and others have struggled with what spirituality is. It's a deeply difficult philosophical question, and I think we skip over it too easily, but it's very difficult to resolve, and I don't know how we will, but within research I think we should go on grappling with it. It's very hard to get these person-centered existential issues in any measurement form, quantitative measurement form I'm talking about. Obviously qualitatively in other paradigms you might. So I'll just quickly skip through. I think we need these clear interventions that are well delineated in plain language, that have a clear theoretical base. None of the interventions that we evaluated had any kind of theoretical base or theological, which was interesting. Thanks very much.